Let's move on now to ischemia. So ischemic disorders now make up the bulk of stroke, whereas we just talked about hemorrhagic disorders, which make up about 15% of stroke presentations. Ischemic make up the rest. We loosely bin these into those that are thromboembolic occlusion, and this is the overwhelming majority of patients who present with stroke, and with the bulk of those being either atherosclerotic or those from atrial fibrillation. Here in San Francisco, atherosclerosis, though a major contributor, is not the majority of our patients. Most of them are atrial fibrillation patients, and as such, we see a slightly older population and a slightly reduced rate of stroke relative to other parts of the Western world. Dissections, whether by a trauma or spontaneous, make up a subset of these, and we'll show a case in just a second. But ultimately, this is the bulk of ischemic issues as it relates to stroke. Arteriopathies, kind of a wastebastic term for abnormal vessels or pathological vessels. This affects more younger patients or young adults, and so people will talk about the moya-moya spectrum, as well as vasculitides and vasculitis as being also contributors to stroke. This is not as much as something that we have to deal with from an interventional standpoint. Our role in these cases really is diagnostic, to really kind of make a determination as to the physiology of the flow to the brain, but also sometimes making the diagnosis. But we do little in terms of the therapies for these particular types of patients. So let's show some cases. So here is a patient with a hyperdense right MCA sign. So this patient has a left hemiparesis. Here's the corresponding CTA. And then these are the perfusion images that accompany it. So this is the blood volume. This is what we use to determine how much of the brain has actually already been injured. Whereas this is the mean transit time, which gives us the information as to how much brain is at risk from being lost potentially. And I'm going to talk about the importance of brain physiology using imaging in just a second, and how that helps us determine which patients might derive benefit and which don't. So this is what we now do. We get up and we do an angiogram. We try to do these as quickly as possible. We do these under conscious sedation. There's evidence to suggest that patients who get general anesthetics can alter their cerebrovascular physiology, and as such can make their outcomes worse. And so we do these under conscious sedation. So these patients are awake and moving. We try to keep them relaxed, obviously, as best we can, but these cases can happen very quickly, and there can be a lot of complexities as to how those things happen. So this patient has an occlusion of the right middle cerebral artery. Here are the collateral vessels coming around from the ACA that are backfilling the middle cerebral territory. This is the lateral projections, and this is what often we did in terms of recanalizing the vessel with what we now use our stent retrievers, and I'll show you some of those in just a second. So this is another case, similar type of presentation, right middle cerebral occlusion. Here's the CTA showing the corresponding image. And then the problem here is not only up here in the head, but we also have an issue down in the neck. So here's the CTA showing both common carotid arteries filling, but once we get up higher, the cervical segment, the right internal carotid artery is occluded. And so what we have here is we have what we call a tandem lesion. And so in the big trials that I'm going to talk about at the end of this section, about 10 to 15% of those cases have what we call tandem lesions, meaning there is an occlusion in the cervical segment as well as an occlusion in the intracranial segment. So what you can see here is reconstitution of some of the internal carotid artery inside the head by external carotid collaterals, but you can see very clearly that there's an occlusion of the middle cerebral, just as we saw in the previous case. So, but what we do is we try to cross this lesion blindly using a microcatheter as quickly as we can to establish where the occlusion is intracranially, because ultimately what we're interested in is reperfusing the brain. So that's exactly what we did. We took a stent retriever, opened this up, and reperfused the end organ. But then we have to come back down and address what's going on in the neck. So this patient has a long segment dissection, which you can see here, affecting the cervical and the petrous segment of the ICA. We initially tried angioplasty to try to open it, but the flow was insufficient. And so we ultimately ended up putting stents in a telescoping fashion from the petrous segment down to the cervical segment. And this is what the flow looks like afterward. So juxtapose this case to another right MCA syndrome case. But in this case, instead of one cervical internal carotid being occluded, both of these vessels are occluded. So this is an older patient compared to the previous one. This is lateral projection angiograms of the common carotid arteries, and it's hard to note, but both of the internal carotid arteries are occluded in this patient. These are the corresponding images of the head in both of these instances, and there's really essentially very little flow getting to the brain at all. And really the only element that's feeding the left hemisphere is via posterior communicating artery collaterals from the vertebral, which you can see here. This is the vertebral injection. So what do? We do the same thing. We cross the lesion on the right side because that's the acute lesion. Patients presenting with a left MCA syndrome, or excuse me, with left-sided symptoms from a right MCA syndrome. We reestablish flow in the MCA. You'll note here that there's a small branch that's still not filling, but this patient had received IV TPA, and given the distance from the initial embolus, we decided to leave this alone. But now we had to address what's going down in the neck. And so this patient has atherosclerosis, a long segment atherosclerotic plaque. And to be conservative, because the patient received IV TPA, we don't want to have to put a large number of antiplatelet agents on these patients initially because they're in this acute phase to try to reduce their symptomatic hemorrhagic rate. We just did angioplasty conservatively. We then waited a couple days, loaded the patient with dual antiplatelet, brought her back and stented the internal carotid artery. And this is what her vessels look like just a few days later. And you can see that branch is obviously recanalized. This is a parametric color map, just gives us time-encoded information as to the contrast density curves. And this is one of the advanced software packages that we use for some of our angiographic cases. So again, the goal of ischemic stroke treatment is to get the vessels open as quickly as possible. This is the kind of material you get out of these cases that come off of stent retrievers, is these small little bits of clot. Sometimes it's bigger than that. I should mention the CT aspects. This is the Alberta stroke scale score, and what they did is they divided the anterior circulation into essentially 10 regions, and what you do is you score those regions based off of their attenuation. And what that's doing is trying to come up with a baseline for how severely affected that patient is, at least on imaging, to determine their core infarct volume based off of that very, very critical non-contrast CT. So let's talk about the trials. So I should first start out with saying that at the end of 2014 to the early part of 2015, there were 5 randomized trials that came out that showed immense effect in terms of the ability of endovascular intervention using stent retriever technology to impact clinical outcomes for patients, both in the immediate and in the long-term setting, for large vessel ischemic stroke. And large vessel ischemic stroke, again, in these cases is limited to the anterior circulation. So that's the ICA and what we call the horizontal segment of the middle cerebral artery. I'm not going to go into too much detail about that, but suffice to say what we're calling these are large vessel occlusions. So most of these patients got IV TPA of some sort. All of these patients got a non-contrast CT. All of these patients received some sort of CT angiogram to make the determination as to where the actual clot was. A subset of these patients received physiologic imaging, i.e. collateral scoring or CT perfusion or some additional imaging component that allowed them to make assessments as to the function of the brain beyond just where the occlusion was and what the core infarct was based off of non-contrast CT. And what I'm highlighting here is the modified Rankins at 90 days, and you can see here the controls. These are the patients who did not receive endovascular intervention versus them, are all statistically weighted in favor of IM3. But I highlight these subset in blue, and you'll notice that the modified Rankins are significantly higher in this group relative to the ones at the other ends, and in large part because this one, the Revascat study, looked at patients at a much longer time point, whereas Mr. Clean, which is the largest of these trials, the one that actually led to the stoppage of these other ones, is lower, but in part because these use some sort of physiologic component to use to make imaging decisions. So what's the role of time? We talked about the role of physiology, but what's the role of time? So Escape, Extendi, and Swift Prime had much faster door-to-groin times relative to Mr. Clean and Revascat, and as such, their effect size is larger. And so time is really the coin of the realm, where it is the essential component in all of stroke. And time is a simple surrogate for physiology. We're going to talk about physiology just a little bit more at the end. But ultimately, if you can get to patients faster, things can get better. So this is what we consider the drip and ship method, meaning that even in patients who have a delayed amount of time, they're still going to derive benefit from endovascular intervention. And we're still trying to figure out, at least in the United States, as to what's the best way to handle these patients. Is it better to send them to a primary stroke center where they can receive IV TPA and then move on to an endovascular center, or is it better to drive further, even if it takes more time, ultimately to get them all of this particular type of intervention, even if it takes a few additional minutes? So what do we find? Obviously, there's significant risk reduction for every amount of time that you can get a patient in for treatment. And this is no better represented in the Hermes data set. So what Hermes represents is it's a study group that took all of the data from these 5 trials and looked at the individual patient information from all of these, which creates a hugely powerful data set that allows us to look at a bunch of additional pre-specified outcomes in the subgroup analysis that we could not look at in the individual trials. Collectively, this again just underscores the power of endovascular intervention for these particular patients. Here's the number needed to treat. It's less than 3 for 1 additional point in MRS improvement at 90 days. Here's the overall intervention. You can see the difference in terms of the interventional population, in terms of the Rankin scores of 3, 1, and 2 relative to those in the control population. And then if you even look at those patients who are not receiving TPA versus those that did, this effect is still quite similar. So the point is that IV TPA, though helpful, is not ultimately the big impactor for these types of patients. This is a busy slide. I show it mainly for record keeping. So if you're going to look at these slides later on, you can look at all of the details here. But I think the important thing to know is that for multiple different outcomes metrics, the effects in the adjusted odds ratio are very much in favor of endovascular intervention. And as it relates to safety issues, hemorrhage, hematomas, and mortality, there's really no statistically significant difference between patients who are receiving intervention but those who are not. So ultimately, though, what we do carries risk. It doesn't carry any sort of significant risk beyond what traditional IV TPA that these patients would receive. So as I mentioned, the pre-specified subgroup analysis, in all of them, all of them favored intervention, even in cases where the patients were young, where we would expect their physiology to be much more helpful to them, and patients who had aspect scores which were very, very poor, 0 to 5, patients with distal occlusions all the way up to the M2, and patients with very, very even low NIH stroke scales. And the point I'm just trying to make here is that though the median patient for any one of these trials doesn't fit any of these categories really, the point being is that if your patient is presenting inside 6 hours with a large vessel occlusion, unless they have some sort of technical limitation or some sort of clinical wish to not receive such intervention, this is the gold standard therapy. This is a nice kind of final concluding image here, just showing the impact of how far out you need to go before you start to lose the benefit of intervention. And this is just within the confidence intervals of this effect, but you can still see it's quite profound all the way out to above 7 hours in terms of presentation. And as such, this rightfully led for a major change in the American Heart, American Stroke Association guidelines in 2015. So I'll pause here.